see this list, it's basically everything that you get in the ICU. You're understanding, it is everything that you get in the ICU. So it is such a common abnormality in the ICU that you probably need very clearly to understand what is to be done with it. Okay, so if you have thrombocytopenia, it could be just sepsis. It could be anything right from sepsis to drugs to anything. So there are multiple causes for thrombocytopenia. Right? Importance is you must understand what are we dealing with here. Okay, so to understand what are we dealing with it, how do you approach this thrombocytopenia before we go into thrombotic microangiopathy? How do you approach this? So your thrombocytopenia comes to you. You have a patient thrombocytopenia. Of course, you're going to look at whether this patient has got infection. You're going to look at whether the patient all the drugs are on. But in the laboratory, how are we going to approach this? First thing, what I will say, what I will look at.
Manual platelet count.
So first, I will look at. I already have a CBC in my hand. Before I go to manual, it's going to take time. I have my CBC in my hand. My CBC has got the presence of a hemoglobin. It has got the presence of a WBC count. If I have a hemoglobin that is abnormal, or if I have a WBC count that is abnormal, I am looking at something in the bone marrow. You understand? Because the whole bone marrow has gone bad, isn't it? If the hemoglobin is abnormal, for example, your WBC count is 70,000, and this is not sepsis. This is something in the bone marrow. So let me do a bone marrow quickly. Are you understanding? Or you got the point? I have to look at the bone marrow. That's the first thing I do. Then the next thing what to do is, what I said, I will do a manual platelet count. Why do I want to do that?
Sometimes.
Why do you want to do manual platelet count? So manual platelet count tells you whether there is true thrombocytopenia. A manual platelet count will tell you there is a true thrombocytopenia. What do you mean by that? This means that when you actually look at platelets in a laboratory with the analyzer, there is a phenomenon called as platelet agglutination or platelet clumping. So when there is platelet clumping, the machine doesn't read that properly. So what is read as 50,000 may actually be 1,10,000 or 1,20,000, maybe like that, because it's clumping. You understand, it's clumping. So if it's clumping, that's why I want to do a manual platelet count under a slide. If they do a manual platelet count under a slide, they will know, oh, this is true thrombocytopenia. You understand? That is why the protocol should be, I see thrombocytopenia, I look at my hemoglobin, I look at my platelet count, I look at my WBC count, I figure out there is no problem there. Okay, that means there is no bone marrow issue here. Probably no bone marrow issue here, probably. Then I will do a manual platelet count to be certain that this is not clumping. Because if it's clumping, then I know that the platelets are adequate. I don't have to be worried. I just wait for some time and probably just read it manually. Or sometimes what happens is these platelets are macroplatelets. Very rarely you have giant platelets. So that also they will see under platelet when they do the manual platelet count. So if it is giant platelets, then okay, the machine is reading it as lesser platelet count, but it is actually normal. Clear? So there are two anatomical abnormalities that may occur. That's why you need the manual. Then what do you do? So what do I want to see in that? So I want to see my peripheral smear of schistocytes. Will come to that when he is doing this peripheral smear for schistocytes. Then, so in peripheral smear, I want to see for everything else. For example, there is pelvic cuvette abnormality. There is different kind of cells that are there, because that will indicate a primary bone marrow problem. For understanding, it will indicate. So when you do a peripheral smear, I want to ask him कि क्या है भाई इसमें वो क्या दिख रहा है आपको? If he sees toxic granulations, he sees pelvic fluid abnormality, he sees something else that is there in the pelvis. It basically indicates a problem of the bone marrow again. Clear? Clear on this? Clear on this? And then based on that, then based on what the patient is, I will want to if it is microangiopathic, if it's hemolytic picture, I will want to do my indirect hyperbilirubinemia, my LDH and things like that, and we'll come to that. Clear on this till now? Clear? Approach is clear? Approach is clear? Approach is, now we come to understanding why that approach is there, because he is going to deal with that as to why that approach is there. Okay? So it's very important to understand this. Very, very important, because when you go to the earlier slide, one slide before this. Yeah. So now one more slide before this. See what he says. It is a rare life-threatening blood disorder. First of all, okay. So in which category of patients you will see? I will finish that. So which category of patients you will see? Usually you see it in young adults, 50 to 60, 40, 50, 60 years. You're not going to see it in elderly people. It doesn't occur in elderly people usually. It occurs in the young people. Okay. around 35, 40 onwards to 60 years, you can see predominantly in that people. You will see predominantly in females. For some reason, you will see predominantly in females. Also, one place where you will see it in younger individuals is in pregnancy. Okay, in pregnancy. So, pregnancy per se has got thrombocytopenia. Okay, on top of it, they have got this problem of TTP in these patients. That is, pregnancy-induced TTP can come. Okay, it's very important for you to understand. Pregnancy is a state where autoantibodies, antibodies are created. So when you actually talked about the fact that the region of the TTP typically involves terminal arterioles and capillaries, very important. How does that occur? To understand that, he basically explained. You have seen this, right? So there are a few things that he mentioned right on the board. So when he wrote right on the board as so what he said was important. So once you understand this, now you should not forget this. Okay? It's very interesting. So this, what happens is that the region is involving where? Terminal arteries and capillaries. Terminal arteries and capillaries. Clear? It is actually terminal arteries and capillaries. This means what is happening over there is clotting. That means clots are forming. Clots are forming. You are understanding? Clots are forming in the terminal arteries. That means ischemia हो रहा है उसको. वो एंड में पूरा ischemia हो रहा है. मतलब ब्रेन के एंड में ischemia हो रहा है. किडनी के एंड में ischemia हो रहा है. End arterioles are getting ischemia. So it's not big kidney arteries. It's not renal artery. So that is why these patients don't have a fulminant renal failure. You are understanding? But they will have maybe a seizure, maybe altered mental status or slightly altered mental status because it's end artery. It's not like one whole handle one. It's not one. You understand? It's all end artery. You are understanding what I'm saying? It's all end of the arteries, arterioles that are having a problem. You understand? So that's why typically the clinical features are not very fulminant. Typically clinical features are not very fulminant. Clear on this till now? Am I clear till now? So it's a very important statement that he said. Okay. The other thing that he says is it uses up the platelets. Now how does this occur? So when he came to this, he says something very important. Where is that? This is what he said. Now what is this? What is happening actually? What is happening is your 1 milligram factor is there in your body. Okay, they come and normally what is happening is they come and join together and they form big chains. They form big chains. And what happens? Your ADAMTS13 comes inside, and it breaks those chains. This is what is occurring. This is what is occurring in your body. ADAMTS13 comes in and breaks these chains into small monomers. They go from large multimers to small monomers. This is what occurs when you have ADAMTS13. Unfortunately, in certain cases, there is no ADAMTS13. You understand? There is no ADAMTS13. So since there is no ADAMTS13, what happens? They form big monomers. And when they form big monomers, platelets go and get stuck into it because platelets are roaming around. Platelets go and stuck onto it. And that's why platelets are consumed. Now what also happens? So platelets are consumed. Large multimers and patients are platelets are consumed. Now when platelets are getting consumed, that means they are forming clots in various parts of the body. They are forming clots right in the vessel. So there is a situation where clots are there, the vessel is not occluded. There are also situations where there are clots forming. Everywhere there are clots forming. There are clots forming in all your distal vessels, and vessels is not occluded, and now blood is passing. What can occur here? The blood is passing in full speed. So these RBCs that are going through that are getting destroyed. RBCs are breaking because you have clots everywhere. So blood is going in full speed. 120 pressure chal raha hai uska. So it is touching and going and physically breaking. They are physically breaking. And when they are physically breaking, what is happening? When they are physically breaking, this hemoglobin is getting dispersed. You understand? Hemoglobin split ho raha hai, and your RBCs are getting fragmented, which are called as schistocytes. So RBC is getting fragmented and it is forming schistocytes. That's why you may get anemia because your RBC is fragmenting. You may get schistocytes that are there. Okay, and third thing you get is an LDH going up because it is hemolytic. It's hemolytic, it's breaking, isn't it? Clear? So if you understand this, you will also understand this behind the therapy behind it. Okay, clear on this till now? Have you understood this? Clear? So this is different from TTP, that's why this is different from hemolytic uremic syndrome. This is different from hemolytic uremic syndrome. Clear? Clear till now? We will come to that. Any doubts till now on this? Any doubts? No, no. Huh? So classically these platelets drop majorly less than 40,000. So the platelets are not like 1,50,000 से 1,50,000 ऐसा नहीं होता है. 1,50,000 से 1,20,000 ऐसा नहीं होता है. इसमें क्या होता है? Platelets 1,40,000 से सीधा 30,000 में पहुंच जाएगा. The drop is tremendous. Are you understanding? The drop is tremendous. So you can't say 1,50,000 it come to 1,30,000. Oh, this may be TTP. It is not TTP. It is not TTP. For TTP to occur, it has to be a generalized problem. It has to be a generalized problem, no? It's not just one area. There are clots everywhere. Since there are clots everywhere, blood is going everywhere. It's consuming everywhere. Are you understanding? So it cannot be just a 1,50,000 to 1,30,000. It has to be a 1,50,000 to 30,000. So they drop a lot. That's why he said in the start that it drops a lot. Clear on this till now? Clear? Let's go. So if I were to ask you, DIC is a completely different thing. Okay. So it's part of thrombotic microangiopathy, but it's different. Okay. So in TTP, I have sent a peripheral smear. I have got schistocytes. What else am I expecting to see? What else are the investigations I am expecting to see? Thrombocytopenia, okay, less than 40,000. LDH is raised. You can get an LDH that is raised. Now LDH is important for what also? It is also important to actually figure out whether my plasmapheresis is working or not. So if I have done, he said one of the treatments is plasmapheresis, right? So I will do an LDH and I will repeat an LDH after my plasmapheresis. If my LDH is going down, what does this mean? RBC breakage is reducing. If RBC breakage is reducing, what does this mean? Yes, the wall equilibrium factor. But what am I doing with my plasmapheresis? I am removing these multimers. By plasmapheresis, what I am doing, those big things that are lying and getting stuck to the endothelium, I am removing all of those. So if I am removing those, what should reduce? Hemolysis should reduce. Isn't it? Hemolysis should reduce. So if you remember, one patient was there on isolation, I was repeating LDH again and again. The patient was on plasmapheresis. This was the reason for doing LDH. Because I have to figure out whether my plasmapheresis is working or not. Isn't it? It's not just sitting on it, it's working or not, I have to figure out. That is why I am doing the LDH. When I do the LDH, I will know, okay, this is coming down, that means hemolysis is coming down, the basic pathology is coming down. Right? Then what else I want to do?
LFT to find out
indirect hypobilirubinemia. So if my indirect hypobilirubinemia will give me a diagnosis, but it will not give me a prognosis. So I am going to indirect hypobilirubinemia. Then reticulocyte count more than 2.5 means bone marrow is okay. You understand? I am going to look my reticulocyte count and maybe a haptoglobin. So these are the few investigations that I want to do in these cases. Alright. Now the question that comes is, you basically said that TTP can be caused by many problems, of which congenital was one part of it, other was acquired. So you have only two parts, congenital and acquired. In the congenital, what is the problem? Adam TS13 नहीं है उसको. Adam TS13 नहीं है congenital, right? So and what is the problem in pregnancy? Antibodies. TTP में क्या हो रहा है? Antibodies form हो रहा है. Antibodies are going, and I told you pregnancy is a state where you may get a lot of antibodies here and there, right? You get antibodies here and there. So what is happening in pregnancy? Antibodies are getting formed which are causing problems towards Adam TS13. So there are two different things. Congenital mein what is happening? There is no Adam TS13. And what is happening in pregnancy? There are antibodies very similar to other pathologies, where antibodies are there in other pathologies. Sepsis antibodies are there. Are you understanding? Clear? Am I clear till now? So if I want to actually diagnose Adam TS13, I have to measure Adam TS13. If I want to think that this is congenital, it is congenital, I have no other way to do it. I'll have to actually measure Adam TS13. Not send it outside to come after some 30-40 days. Okay, understand what I am saying? Adam TS13, if I want to figure out there is congenital deficiency, I have to send Adam TS13. There is no other way to figure out. Right? I'll send it across, and around 25 days later, 15-20 days later, I'll get the values. Usually, Adam TS13 actually cause this kind of situation. It has to be less than 10%. Okay, to cause a TTP. Clear on this? Clear? Right? Now, let's cut across to a situation where you have autoantibodies. There are any antibodies. That the antibodies is causing this problem. Okay, so the treatment of antibodies, first of all, the first emergency treatment is what? I have to remove these multimers. I have to remove the multimers. So the emergency treatment is plasmapheresis. And now you understand why it is an emergency treatment. Because what is happening? There is ischemia happening. Small vessel ischemia happening. The brain is getting affected, the kidney is getting affected, the various organs are getting affected. It's an emergency, no? Because you are losing organs, ischemia is occurring. So it becomes an emergency. So plasmapheresis you need to do. For plasmapheresis, what do you require? To put you need a dialysis catheter. You need a dialysis catheter. You understand? Now his platelets were less than 40,000. That's what he said. He started by saying that the platelets are less than 30,000. What do you do now? You are understanding what I'm asking you. I'm asking you have a patient of TTP, the treatment of choice, emergency plasmapheresis. Plasmapheresis here is an emergency procedure. Because as you are waiting, he is getting more ischemic. He has come to you because he is ischemic. He has come to you because he is ischemic. That's why he has come to you. Otherwise, the patient had no other symptoms. Patient started developing altered mental status. Patient started developing some renal issue. Creatinine started going on. That is how this patient comes to you. And then you found the platelet should be 20,000. That means ischemia is already occurring. इतना अगर प्लेटलेट 1,50,000 से 3 लाख से वो 50,000 पहुंच गया है तो कितना प्लेटलेट्स कंज्यूम हो गया सोचो बॉडी में पूरा का पूरा प्लेटलेट्स कंज्यूम हो गया है एंड कंज्यूम हो गया जिसकी वजह से प्रॉब्लम हो रहा है राइट सो नाउ आई वांट टू पुट दिस लाइन व्हाट डू आई डू सो यू डोंट गिव प्लेटलेट्स फर्स्ट थिंग डोंट गिव प्लेटलेट्स क्योंकि प्लेटलेट व्हाट हैपन उधर जाके और चिपकेगा वो जहां पर मल्टीपल है वहां पर जाके और चिपकेगा क्लासिकली टीटीपी पेशेंट्स व्हेन यू आर पुटिंग लाइंस they don't bleed. Classically, they don't bleed. That doesn't mean you don't put it with the ultrasound guidance. You always put it with the ultrasound guidance. But you don't give platelets to put a TTP because here INR and PTT is normal. You don't have to wait for all that nonsense. The INR we said in the starting, INR and PTT is normal. The INR PTT is normal. You don't have to wait for all that nonsense. You have thrombocytopenia. Question is, you want to give platelets or no? Answer is no. Clear? If you give platelets, there will be exacerbation of the problem. Right? But what you can do is something what she said. But that is not going to change your platelet count. So, say for example, you have to do plasmapheresis. Now, plasmapheresis requires your technician to come. It requires the machine to be ready. It requires the line to go. It's going to take a while. It's going to take a while. Line will take another 25-30 minutes. Then the plasmapheresis machine will come. It will take another 15 to 30 minutes. You will arrange for plasma because plasmapheresis has to be done. Then also, it's going to be at least 3-4 hours window that is going to occur in the meantime. So, what do you do here? What do you do? So, what is our problem? We have less of and less of what? Adam TS13. We have less of Adam TS13. Okay. If I give little bit of Adam TS13, patient will get better. From where will I get Adam TS13? From somebody's plasma. From where I get Adam TS13? From somebody's plasma. You understand? I don't require higher amount. I just require more than 10%. Are you understanding? So if I give some amount of Adam TS13, there is a possibility that some of these multimers will be actually taken off. So what do I do in these cases? I give plasma. How much plasma? 2 plasmas I give stat. Of course, it is going to be that is why you don't give plasma only because you don't give volumes and volumes. Every 4 hours you have to give 1 plasma, 1 plasma. Every 4 hours. You first give 2 plasmas and then every 4 hours give 1 plasma, 1 plasma, 1 plasma. You understand? Of course, it's going to be too much of a volume for this patient. There may be a problem, there may be this, there may be that. You understand? That is not the treatment of choice. But if you are going to wait, rather than waiting, you give 2 plasmas. Here, and meanwhile arrange this plasma is not given for INR, it is not given for PTT. It is given for what? It is given for Adam TS13. It is not given for anything else. Okay, so all patients should be. This is you understand why it should be in the intensive care because it's emergency. You need to do things quickly. You need plasma therapy. You need to do things. This is very important. Should be avoided. Okay, even in life-threatening bleeding, probably it's something that you will probably want to avoid here because it's going to be very dangerous. It is using plasma therapy and steroids. Where you will not use steroids? Which condition of TTP you will not use steroid? Why are you giving steroid? So question is why are you giving steroid? Why are you giving steroid? What is the pathology here? What is the pathology here? Raushika, think hard. You're not thinking only properly. What is the problem here? Antibodies. What is the best way to remove antibodies? Steroid. If you reduce your inflammation, if you give an to get an antibody down, what do you give? Steroid. किधर भी बॉडी में एंटीबॉडी है, for to get that pocket information, if I have to get that antibody down, what do? I give steroids, right? So in which condition of TTP you will not give the steroid? Congenital TTP, because in congenital TTP there is no antibody. There is no antibody. So if you have diagnosed congenital TTP, there is no role of steroid. You understand? Because it's congenital TTP, there is no role of steroid. This patient, if he comes from outside and says, I have been diagnosed as TTP congenital, and I am having platelet of 20,000, what will you offer? Plasmapheresis. Clear? Clear on this? You will offer what? Plasmapheresis. Clear on this? Congenital TTP will not respond to steroids. Clear? How much steroids? So you said it has to be given, steroid has to be given. So normally for any antibody in your body, average dose of steroid for every individual is 10 milligram per kilogram for 3 days of methylprednisolone. That's why we give 500 milligram pulse doses. Clear on this? 10 milligram per kilogram methylprednisolone is what you are supposed to give for any antibody in your body. Let it be catastrophic, APLA, let it be whatever you want to talk about. Any antibody, 10 milligram per kilogram is usually the dose you are giving. So it's 500 milligrams for an average 50 kilo individual. It's 500, 500, 500 for 3 days. Clear? It's a rough guide to understand for any antibody. Right? Another investigation that you like to do in this case is an ANA. Because what is usually occurring in those patients who has TTP, they usually have 50% chances of positivity with ANA. And why is that important? Because ANA can be indicative of antiphospholipid antibody syndrome, which is also presenting a very similar way. Clear? It's also presenting a very similar way. Minus all the peptides that we're talking about. Clear? Minus all the peptides that we're talking about. Clear on this? So you understood plasma therapy? So when you said these three things, is typically treated with plasma therapy. It's actually plasma exchange. Typically. Plasma exchange, then plasma therapy, plasma exchange going to take time, and then steroids to actually reduce the antibody load. Rituximab may be also used because it's also responsible for reducing the antibodies. Where is HUS? Everyone on HUS? Yes. So you should now go to HUS rather than DIC. You should first go to HUS because it's very similar to TTP. So you must actually explain HUS now. Let's go to HUS now. Yeah. What do you understand by HUS? First of all, what do you understand by HUS? Now, if I want to differentiate HUS from TTP, how will you differentiate it? Let's go one by one. Okay. What is the problem here?
GI symptoms from gastroenteritis, infection, toxin,
What was TTP? No, TTP, what was the pathophysiology?
It was adenylase deficiency
Or
antibodies.
Here what is the problem? Toxin. So in HUS there are two types. One is the Shiga toxin and the other is the atypical type. Okay, remember, understand. HUS, there were two types. Which was the first type? The one which you are talking about. The one which you are talking about is the typical type. Typical type में क्या हो रहा है? There is, you have a GI problem, you have Shigella, you have diarrhea, you have dysentery, you have blood in the stools. Okay, and then a couple of days later, you come into the hospital with renal failure. So you can understand how difficult this becomes. Because it could be just acute renal failure because of the fact that the patient is not had food or tremendous diarrhea. Isn't it? But here, the renal failure is different. What has happened over here? Here the situation is, there is a Shiga-like toxin that is formed. That toxin goes inside, causes endotheliitis. You understand? It is different from Adam TS13 multiples that are forming. It has formed endotheliitis, which has thus caused platelets to get into that place. You are understanding? So when you went back, we had that slide that says that Shiga-like toxin is, so the commonest is this one, typical. Okay, whereas complement abnormality is atypical. Complement abnormality is atypical. So when you look at this, disease, younger people, 1/4 patient without diarrhea, acute kidney occurrence 15. So the major issue here that you understood from Shiga-like toxin is the TTP and the difference is what? Once you understood endotheliitis is occurring. Okay. Second thing, They are, as she said, she's preceded by a diarrheal illness. So it is not diarrhea today, tomorrow TTP, tomorrow drop in platelet count. It is diarrhea, 4-5 days, 5 days later renal failure. Clear? That is how it is. And the third thing is this patient present more with renal failure. That's why it's called hemolytic uremic syndrome. TTP doesn't present with renal failure. What we said TTP? Mild renal insufficiency. We said na creatinine is mild renal insufficiency, less than 2 creatinine over. Whereas these present with renal failure only. They present with acute tubular necrosis. Clear? They may present with renal failure. There's one basic difference that you can get between them. Okay. The other thing that you can have with gigadoxin is with atypical HUS is they are complement mediated. These complements are antibodies and they cause problems. Complement mediated. Clear? So how to diagnose these patients? So in TTP we were able to diagnose by doing peripheral smear for schistocytes. We were able to say microangiopathy, hemolytic anemia. So how do you? So here this is a problem. You can't really diagnose them because if you want to say complement levels, it will take you a long time before it comes. It's an issue. It's like congenital Adam TS30. You don't get these complement levels. So it will take a very long time before you actually diagnose them. So how you diagnose this? By clinical features. You find the thrombocytopenia, which is alarming, along with the renal failure. But unfortunately, the treatment is completely other. In TTP, the treatment is plasmapheresis. Here, plasmapheresis don't work. You understand? Here, plasmapheresis is not working. So when you come here, when infection related, the treatment is supportive. The treatment is if the patient develops diarrhea or dysentery and then comes in with thrombocytopenia, the treatment is supportive. You give IV fluids, you try to get urine out. If urine is not coming, put them on dialysis. The treatment is largely supportive. Are you understanding? The treatment is largely supportive. So most often than not, these people progress. Okay, they'll progress to renal failure and all this thing. So you hear this many times that हम लोग को diarrhea हो गया, dysentery हो गया, admit हो गया, फिर हमको dialysis लग गया, तब से dialysis चल रहा है. That would have been part of hemolytic uremic syndrome. Are you understanding? Hemolytic uremic syndrome. So that's all part of hemolytic uremic syndrome. Clear on this? So this complement factor, these problems, which is called atypical HUS. This is called atypical HUS. These are not. You cannot diagnose them by doing. Complement factors you can send, but it takes a long time to come back. The rest of them are all clinical. If you look at it, rest of all them are clinical. Clear? Clear? Any other queries? So there is one drug that you may use in complement mediated, which is called as eculizumab. So that is one drug you may use it in that time. Yes. So this urine and stool test is to understand Shiga-like toxin, and the treatment over here is eculizumab, atypical monoclonal antibodies. That is the only place where probably you can use it. Okay? And you may use it when there is complement mediated. That is atypical HUS, plasmapheresis. You understand? But in typical, like in Shiga-like toxin, which you normally will see, you will not be able to do plasmapheresis. Clear? Okay? So it's basically supportive. It's only in atypical HUS where you use plasmapheresis. Clear? Any queries? So let's go to DIC now. Health we have done, so let's go to DIC. With other features of all this. And ITP is a diagnosis completely of exclusion. Completely of exclusion. You understood this much? So, what will come positive? Your clinical examination, which will say that blood pressure जिधर कफ लगाया वहाँ पर तुमको ये दिखा, जहाँ पर blood you have taken वहाँ पर you see something bleeding from the gums. You know they can bleed from the gums and all, and their platelets are alarmingly low, 10,000, 1,000, even zero. Okay, that's how it is. So, would you do a bone marrow? So, everything is negative. If everything is negative, then would you do a bone marrow? So, that is a topic of debate. Okay, because everything is negative. You have got everything to be negative. The peripheral smear is not showing anything. It is just showing low platelets. It is not showing anything that is difficult over there. Sometimes it will show megakaryocytes because there are less platelets. The bone marrow starts making bigger platelets. You understand? Because sometimes it may start showing, so megakaryocytes might be seen, clumping might be seen. But you will not see specifically like anything in the smear. You understand? There is no schistocyte because the pathology is different here. You understand? The pathology is completely. You understand? The pathology is completely different. You are not seeing schistocytes. You are not seeing pelvic cuvette abnormalities. You are not seeing all those problems that we are seeing. We may see presence of megakaryocytes. That is the only thing that we are missing. But that only indicates that the bone marrow is trying to produce more platelets. Bone marrow is trying to produce and it is unable to produce. That's why it's forming megakaryocytes. So in this case, it is doubtful whether we should do a bone marrow. So at the moment we are doing the bone marrow because we don't want to be missing out something like a very atypical leukemia or things like that. Okay, we are just doing that as of now. But bone marrow will probably show you what? Normal. It may show you normal with with thrombocytopenia. It will show you with low platelets. It will show you megakaryocytes. Okay, it may not show you anything more. But what is important for you in this case is to actually measure the spleen. What is happening here? Antibodies are getting coated with platelets. That will go into the spleen, and then no splenic sequestration. Spleen is going down and down. छोटा छोटा होता जा रहा है. अटक रहा है ना उधर जाके. Platelets जाके उधर अटक रहा है because macrophages are taking those platelets towards that place. Okay, and फिर वो धीरे-धीरे spleen धीरे-धीरे कम हो रहा है कम. So if you get platelets of 20,000 and you get splenomegaly, it is not ITP. You understand? So if you get platelets of 20,000 and you get splenomegaly, it is not ITP because if platelet sequester हो रहा है, platelet is going and it is obstructing that place. You're understanding? So the spleen should actually go down. तो अगर तुमने जाके splenomegaly report किया अल्ट्रासाउंड में, it goes virtually rules out ITP. It is not ITP. So that's why it's a diagnosis of exclusion. You understand? It's a diagnosis of exclusion. Clear?
Can we do platelets?
So no, we don't need to give. They normally don't have major bleeds. They have minor bleeds.
So this is a commercial problem.
Now that we know ITP, now that we know HUS, now that we know TTP, now let us understand what is different here. Okay, what is different here? So let me ask from you, what could be different? Okay, so tell me the difference between this and say any of the other earlier ones. What is the major difference between this and any of the earlier ones? Bleeding from maybe ITP also bleeding.
No, but like a bleeding time, PPI.
Yes, very important. So this is the only condition. This is the only condition that we discussed in among all the thrombocytopenias that we discussed, which has got alteration of INR, has got alteration of PTT, and has got probable alteration of fibrinogen. Till now, none of these had any of these. Okay, and the fourth thing what also is showing is, apart from this is D dimers. We didn't talk about it till now, right? So this is the first time we talked about these 3-4 things. So D dimers yours would be extremely high. Okay, so virtually if you have, because DIC is what? It is uncontrolled coagulation. It's uncontrolled clots. I'm getting forming. You're understanding? Your uncontrolled clots are forming. So invariably the D dimer has to be elevated. Wherever there is a clot, D dimer will be elevated. And then it is not one clot, it is widespread. So what should be D dimer? You understand? So unlike a pulmonary embolism where the D dimer is small in one place, or where the clot is in one place, here there is what is the situation? It's all over the place. So what should be a D dimer? So that's why when you say DIC, there is a DIC score, ISTH DIC score. It's called ISTH DIC score, which actually involves INR, it involves PTT, it involves platelets, and it involves D dimers. So if you are considering DIC to be part of your diagnosis, you need to send all 4 of them, and there is a score that says if these are there positive, then it comes to high chances of DIC. Now the issue is what is now? So that is about one diagnosis, one thing about. What is the second thing? The platelets will not be like 20,000. Which now what we are talking about in the platelet count. You have platelet 30,000 HUS, in TTP it's 30,000, ITP it's 10,000. You understand? The platelets are going markedly down, right? But in DIC, progressively 150,000, 120,000, then 80, then 90, but it will not go to 30 and 20. It will not reach that. Are you understanding? It is not going to reach that. It is not. You got the point what I am saying? So it's not that DIC will have platelets of. That is the second thing. The third thing is here you have a history. No, these patients will have a history, clear-cut history, that he had a sepsis or a septic shock or something like that, which is catastrophically caused this problem. there's a history. The history is very different from what you had in TTP, very different from what you had in hemolytic uremic syndrome. Okay, but the history is very classical. No, a lot of other things are happening in this particular patient. That's why DIC, the history is another defining point over here. Clear? So that comes. So what is the commonest cause of DIC that we normally talk about is actually trauma and sepsis. Trauma and sepsis. And that's why sepsis itself can cause a coagulopathy, which may not be DIC. That is called as sepsis-induced coagulopathy. What's it called as? Sepsis-induced coagulopathy. Sepsis-induced coagulopathy has got something called a SIC score. Sepsis-induced coagulopathy score, which actually involves platelets, which involves the SOFA score, and I think which involves the INR. Okay, so someone just please open it in the net and see. I think these three things that are there. Okay, so sepsis-induced coagulopathy score, which will actually tell you that this may not be fulminant DIC, this might be sepsis-induced coagulopathy, and that is what we normally have. More than DIC, what we have usually is sepsis-induced coagulopathy. So let's just open up the score. What is the score? SOFA score. So if you look at bed number, the last bed who we are resuscitating, the lady. So SOFA score is very high. You got platelets that is on the lower side. And then the INR. So now what is she? Is she DIC or is it sepsis? It is sepsis-induced coagulopathy. I don't understand. It is sepsis-induced coagulopathy. That patient has got a low platelet count. So it is sepsis-induced coagulopathy. And if you see your platelet counts has been slowly coming down. It was 2,40,000, then it became 1,30,000, then it became 1,10,000. So that is why I was saying the other day when the platelets were on the lower side in the ward, in the hospital, why wasn't this evaluated? You understand? Because platelets going down is an element of sepsis-induced. So when did the sepsis occur for that patient? A while ago. Are you understanding? Patient was septic at that time, a while ago that was, and I think now it is all related to the pleural cavity. Because after the tap, probably repeat tap has shown exudative pleural effusion. But exudative can also be malignancy, periodicity malignancy. Okay? So treatment largely for DIC is supportive. Treat the cause, sepsis treat the cause, ARDS treat the cause, trauma treat the cause. It's largely supportive, and we don't know which part, but the important thing that you rightly said is sepsis causes extreme high mortality, extremely high mortality. Okay? So when DIC causes extremely high mortality. Okay? This is different from heparin-induced thrombocytopenia, one entity that we didn't discuss today. Okay? So we leave that to concern next time. Heparin-induced thrombocytopenia, right ventricular dysfunction. दोनों करना है तेरे को.